Hello, and welcome to the Clinical Care Options Oncology podcast. I'm your host, Tim Quill. Today's episode features Dr. Charles Ryan from the University of Minnesota in Minneapolis and Dr. Neal Shore from the Carolina Urological Research Center in Myrtle Beach, South Carolina. They will be answering questions posed during a recent live program on PARP inhibitors for patients with prostate cancer, with topics including repeat testing for DNA damage repair mutations, managing patients with PARP inhibitor intolerance or resistance, and the impact of monoallelic versus biallelic BRCA mutations or ATM mutations on treatment decisions. This episode is part of a larger educational program titled Beyond BRCA, Exploring PARP Combinations in Prostate Cancer. For more information on Dr. Ryan and Dr. Shore, along with a link to the complete program, including downloadable slide sets, an expert commentary, and an on-demand webcast, please visit the show notes for this episode. Now let's get started and hear what the experts have to say on these important topics.
I really appreciated that you said, test. And as you just concluded, we've now entered in 2020 this era of personalized, precision-tailored biomarker correlation with a therapeutic for the PARP inhibitors. There's just no doubt about it. Mm-hmm. And you can't offer this discussion to patients unless you test. And you made the point of reviewing germline and somatic testing, and somatic is tissue and liquid. The question from the audience is, let's assume you've done that, and how often are you getting additional somatic testing when you change other lines of therapy? Are you finding that valuable?
Yeah, so I am doing it some, and in particular, I've done it in a couple situations. For example, where the patient had a prostate needle biopsy 15 years earlier, or 10 years earlier, and I question not only the quality of that tissue anymore, but I question whether other alterations have occurred that render that old tissue sort of less relevant. So that might be a case where I can order a cell-free DNA test, or I might obtain a biopsy of a material if it's available. Of course, doing biopsies on metastatic sites is not always easy. It depends on some expertise within interventional radiology or whomever would be able to obtain that specimen. So if you have an old, the short answer to your question, if you have an old specimen that you may not trust, maybe cell-free DNA. I think that the idea of serial biopsies or serial acquisition of tumor for sequencing probably still remains in sort of the research realm. I mean, it is fascinating work because we are seeing that the tumor evolves right in front of us. And that whole issue about the BRCA2 reversion mutations, that was detectable in cell-free DNA because basically a new form of BRCA emerges on cell-free DNA.
Yeah, thanks, Chuck. And you mentioned the adverse reactions and the fact that it's mostly pretty grade 1, grade 2 GI, really low single-digit percentage of grade 3, 4s. The main thing is the anemia. Mm-hmm. It presents itself pretty early on and doesn't seem to progress, and typically resulting in a lot of transfusion requirement. But nonetheless, right. Important to check a H&H when using rucaparib and olaparib. The question that we got from the audience is, we're aware of AML and MDS in breast and ovarian cancer. Any reports in prostate?
I won't say that there have been none. I just don't know of many. So that is something that, of course, would need to be watched out for. When these trials first started, that was a little bit more of a concern, but I think, we certainly didn't see any in the PROfound study. And the other big studies that are underway have not yet reported any significant uptick in AML or others. So I think that, in particular, when you're thinking about patients with metastatic CRPC who have a prognosis of a relatively short period of time, 2-3 years, and you have a therapy here that improves survival, I consider the benefit far outweighing the risks, if there even is a risk of acute leukemia. There's a couple of really good questions that I think we could benefit from going over. One is, if resistance to PARP inhibitor therapy develops, should we switch to the other one? Is there cross resistance? What do you think on that?
Well, that's a great question. I have not seen a study doing sequencing of PARP inhibitors. I've been using PARP inhibitors now in trial and now with approval for the last 3-4 years, but I've never had an opportunity, as opposed to what a lot of us do when we sequence AR pathway inhibitors, right? We do that a lot, even though that a lot of that data is not very impressive. Everybody has their anecdotal experience, but to answer it, briefly, I have not. I don't know. What about you?
I actually don't think we should sequence PARP inhibitors because I think that it's a very different story from the AR drugs. And the only time where I could see that one would switch from one to the other would be if a patient has untoward side effects and you want to switch for that reason, or if we had some compelling evidence that there was some pharmacokinetic problem, right? The patient's taking the drug, but they're not getting enough drug level or something like that. But I think, assuming those aren't the case, the tumor that develops resistance to a PARP inhibitor is probably resistant to PARP inhibition, and that I think is that's sort of at least my working philosophy.
And then one other one came in, Chuck. This is always one thoughts on a patient who's monoallelic versus biallelic and the therapeutic implications.
Yeah, so that's a great question, and I think that the situation is evolving there a little bit. Early on, there was sort of this assumption that biallelic loss of BRCA2, for example, would be the most sensitive to PARP inhibition, and that hasn't really borne out quite so much in the data. And I think in a kind of a good way, in that we see that most patients aren't biallelic that we can see, so you don't have two BRCA2 alterations, and that there are great responses to PARP inhibitors even in the monoallelic. The niraparib study, which we didn't go over in great detail, that was presented, it was at ESMO back when we had an in-person ESMO, and I haven't seen an update, looked only at biallelic BRCA2 alterations in niraparib, and they reported a response proportion that was very close to what we're seeing with rucaparib and olaparib in the 45% range. So I don't know that it really matters. And I certainly would twist that question around. I would say, don't hold back on using a PARP inhibitor if you're only seeing a monoallelic. If you're seeing a biallelic, certainly give a PARP inhibitor, but I wouldn't assure the patient that they're definitely going to respond.
Yeah, I totally agree with that. I think the way I've kind of assessed it is, there's a difference potentially in being monoallelic, biallelic in the germline. If you're biallelic in your germline, you're probably destined to have a lot of very other aggressive malignancies. The monoallelic, biallelic in the tumor DNA subsequently, it's still a lot of, uncertainty as to that's going to ultimately make a difference. But yeah, I look forward to more data coming forward on that. Yeah.
Great. I'll take a question, and we have a minute. There's a question about ATM, and ATM is really interesting. ATM was assumed to be a PARP inhibitor sensitive mutation, and as we kind of went through it, I think we went through it relatively quickly. But ATM don't really appear to benefit. I just submitted an abstract to ASCO on ATM mutations in prostate cancer, and I'll just tell you that basically. What we see is that ATM is a very different tumor biology from BRCA2, and ATM is actually not a DNA repair protein; it's a DNA damage sensing protein. So it's sort of like an alarm rather than a repair. And so we may need other strategies for ATM. There are things like ATR inhibitors that are being tested, and other approaches. So more to come on ATM. After BRCA2, ATM is the most common alteration. So it's good to be asking this question. And I think it's good to be looking at these patients. We're talking about 5 or 6% of the CRPC patient population, which may seem not like a lot, but that's where we are in 2021, which is to say, now that we can identify these mutations, we need to be pulling them out and thinking about them individually as what types of approaches we're going to take.
Yeah, I agree with that. I mean, you see these ATMs, if you test a lot, you'll see them. The data isn't incredibly compelling for PARP inhibitors. There are some patients that do make it in the positive direction in the waterfall plots. You do see some response, you see some PSA declines. You certainly see some nice CDC declines, but you're absolutely right. So I think for right now, we're sort of a little bit in a rock and a hard place. That's a real unmet need. I like the idea of looking at ATR and potentially some other pathways, as you showed earlier in your presentation, and even potentially degraders.
Thank you very much, Dr. Ryan and Dr. Shore, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, Beyond BRCA, Exploring PARP Combinations in Prostate Cancer, and to download the slide set associated with this discussion from the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.